technically levocimendin is a calcium sensitizer, which I think of as a euromilrinone, if you will.
Milrinone wearing a beret.
Or perhaps holding a baguette.
Or milrinone in a tiny car stuck behind a herd of sheep.
Absolutely, yeah. So for those of you that are interested, it does bind to troponin C in a calcium-dependent manner, which subsequently increases contractility. So to riff off of what Nick said, this is kind of milrinone from across the pond. Essentially, what you're seeing with levocimendin is a bit of an inodilator effect in that it causes vascular smooth muscle dilation through mediation of potassium channels, in addition to the increase to contractility that we do see.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your host, Dr. Nick Mark.
And I'm your co-host, Dr. Cyrus Askin. On today's episode, we're going to talk about all things inotrope. What are they? Who are they? Where are they? When are they? All that good stuff. Not that that made any sense.
Yeah, what are they? How do they work? When do we use them? And as usual, we're going to do some fun cases to tie it all together. So, why don't we just jump into it? Get to the good stuff.
Let's do it. All right. So first off, Nick, why don't you tell us a little bit about inotropes? Specifically, what are they?
Great question. So inotropes are medications that alter the force of cardiac contractions. We'll get into the nitty-gritty of how they work in just a minute, but there's a couple of terms we should just unpack from the start. One is a positive inotropic effect, which is where you have an increased force of contraction. And another is a positive chronotropic effect, which is where you have an increased rate of contraction. Importantly, as we'll see, it's possible to have drugs that are positive inotropes without necessarily being positive chronotropes. So there are drugs that can make the heart beat harder, more forcefully, without necessarily beating faster.
That's a great point, Nick. And also, as we've said on prior episodes about shock and vasopressors, the ability of the heart to pump really depends not just on inotropy, but also on preload and afterload. So if you'll recall, cardiac output is the product of heart rate and stroke volume is a function of contractility, as well as preload and afterload, whereby contractility and preload are generally going to increase the stroke volume, while afterload is generally going to decrease your stroke volume. And so really the relationship admittedly does get kind of, wonky at the extremes and in certain situations. But in general, remembering this relationship, I think, should keep you on the straight and narrow.
Absolutely right. At the extremes, if your heart is beating so fast it doesn't have enough time to fill, for example, these terms start to interact. But let's keep it simple. Cardiac output equals heart rate times stroke volume. Inotropes can act as a positive inotropic effect, which is increasing stroke volume, or they can act as a positive chronotropic effect, increasing heart rate. So kind of two different knobs to turn to increase cardiac output, which is the goal when you're giving somebody an inotrope. So obviously this can get complicated. Let's think about another element of this, which is, some of these drugs are going to increase afterload. Some of them are inoconstrictors, and some of them can decrease afterload. Some of them are inodilators. We'll talk about that more in just a second. Before we get more into the weeds, though, we should probably talk about what these drugs are, what's in the toolbox.
Yeah, that's a great place to kind of pick back up. So really there are a few different categories. So you have your catecholamines. Those are going to be agents that have a catechol ring. And examples that are inotropes and catecholamines would be dobutamine, epinephrine, dopamine, and isoproterenol. You've also got phosphodiesterase inhibitors, and really the only one in the class that we use consistently or that I'm really aware of would be milrinone. And then finally, we have this category of sort of other agents, and those are other drugs that have inotropic effects. And specifically that would be, or the ones that we're going to focus on anyway, are going to be angiotensin 2, levocimendin, and calcium. And I think maybe we'll just go ahead and unpack some of those specific drugs right now.
Right. So fans of the show, remember that in the vasopressors episode, we talked a bit about angiotensin 2. It's a peptide hormone. We typically use it as a vasopressor, but in addition to being a rather potent vasopressor, it also has some positive inotropic effects and positive chronotropic effects. And it also increases endogenous catecholamine production. So it kind of gets you to release your own inotropes as well. For this reason, it's a good drug to use in cardiogenic shock, and that's where it is used by and large.
Awesome. So next, we'll talk about levocimendin. So technically, levocimendin is a calcium sensitizer, which I think of as a euromilrinone, if you will.
Milrinone wearing a beret.
Or perhaps holding a baguette.
Or milrinone in a tiny car stuck behind a herd of sheep.
Absolutely, yeah. So for those of you that are interested, it does bind to troponin C in a calcium-dependent manner, which subsequently increases contractility. So to riff off of what Nick said, this is kind of milrinone from across the pond. Essentially, what you're seeing with levosimendan is a bit of an inodilator effect in that it causes vascular smooth muscle dilation through mediation of potassium channels, in addition to the increase to contractility that we do see.
Right. And so for those of you across the pond, you're probably more familiar with this. We're not telling you anything new. For those of you here in the US of A, it isn't approved for use. It's been approved in various countries in Europe since about 2000, and it's currently under FDA review right now. But, since it's not available here, we're not going to talk about it more. If and when that changes, we'll just have to have another podcast all about this drug.
Awesome.
Euromilrinone, we'll call it.
Indeed.
Last but not least, and maybe the most overlooked inotrope, in my opinion, is calcium. So calcium, as we'll see when we dive into the mechanism, is vitally important for how these drugs work. And in critical illness, many people are hypocalcemic. And so giving calcium can both increase contractility, it can act as an inotrope, and it can make the drugs that you're also giving more effective.
Awesome. Yeah. So great discussion on those agents. So now that we've outlined some of those agents in that sort of other category, I think now we can get a little bit more into the weeds about how these agents work in general and in broad strokes. And I'll tell you guys right now, if you're not into mechanistic discussions, you might want to go ahead and skip ahead, because we're about to get into the weeds for sure.
No one wants to skip ahead. Though, trigger warning, for the next minute or two, I'm going to use some scary words like G-coupled protein receptors and cyclic AMP. So if this is going to induce like pharmacology and biochem PTSD, just bear with me. Trust me, I think the juice is worth a squeeze. So
no pun intended.
That's right. So let's imagine you go out for a run. Your muscles start contracting, using oxygen. Your mixed venous oxygen stats start to fall. That means the blood coming back to the heart has lower saturation. So you need to breathe more. And then your heart needs to pump more to keep delivering oxygen. So to do this, your adrenal glands are going to release catecholamines, principally epinephrine and some norepinephrine. So how this works is epinephrine is going to go through your blood. It's going to bind to beta-1 adrenergic receptors on the heart, where it has several important effects. So first off, it binds to a G protein coupled receptor. And you can think of this as kind of like a light switch. When epi binds to it, it flips the switch on. Now, immediately, the flip of the switch, the switch on is going to start doing things. So there's a G protein, it's going to be bound to GTP, and it's going to start via a signaling cascade having a positive chronotropic effect. Now, moving down the pathway, now this G protein is going to activate adenyl cyclase, which is going to start producing a ton of cyclic AMP. It's an amplifier. And cyclic AMP is going to do a couple of things. First off, it's going to activate calcium channels. Remember, I said calcium was important. It's going to bring more calcium into the cytosol. Remember, calcium is involved in all that actin, myosin binding, and it generates the force of contraction. So it's the second step, which is giving us the positive inotropic effect. Now, there's another important thing that happens here at the same level, though. Cyclic AMP is also going to activate various protein kinases that lead to vasodilation. And we don't really need to say exactly how that happens. Just trust me. You're going to have this pathway that's going to immediately increase heart rate, and then via a second messenger, increase the force of contraction and vasodilate.
You wanted to say phospholamban here, didn't you, Nick?
I know I did. It's like the stupidest, funniest word. And apologies to anyone who's dedicated their life to studying it, but phospholamban is just really funny. Anyway, so to summarize, beta agonist binds to beta-1 receptors that directly cause increased chronotropy. And then farther down the pathway via cyclic AMP, they also cause increased inotropy and vasodilation. But remember, epinephrine is not just binding to the heart. And so it's going to circulate through the blood, and it's also going to have effect on vascular smooth muscle via alpha-1 adrenergic receptors. This triggers a different signaling cascade that we don't need to get into that will lead to vasoconstriction. What this means, and the whole reason why we're talking about this, is that depending on which receptors and where in the pathway inotropes work, they can cause different combinations of inotropy, chronotropy, and then either vasodilation or vasoconstriction. And I should just add that for those whose heads are spinning from this, maybe like ours, we've got some pretty pictures on the website that will help hammer this stuff home if you want to see this visually.
That's awesome. Yes, absolutely. So we'll try to get those heads back to midline as best we can. So now that we've reviewed the mechanism of these drugs in general, I think we can get into the important ways that different inotropes differ from one another. Because if they didn't, then we would really just have one. We wouldn't need to torture ourselves with this whole armamentarium, right? So the first one we'll talk about is dobutamine. So that's a pure beta 1 agonist. It's going to trigger increased chronotropy, increased inotropy, and vasodilation for the same reasons that Nick just described. Epinephrine, on the other hand, is a beta 1 and alpha 1 agonist. So you're going to see that chronotropy and increased inotropy, but you're also going to see vasoconstriction with epinephrine.
Exactly. And so this is the difference of which adrenergic receptors it's binding to. While we're talking about drugs that bind to adrenergic receptors, we should mention dopamine. So dopamine is a lot like epinephrine, but it differs just a little bit because in addition to binding to both alpha and beta adrenergic receptors, it also acts on cardiac dopamine receptors. This is probably why dopamine causes more tachycardia than other catecholamines. It's also important to remember that even though you probably learned in school that dopamine has all these cute little different effects at different dose ranges, precisely defining those ranges is really hard and kind of varies a lot between different people. So don't think about numbers, think about dopamine as high or low dose.
Awesome.
Another drug we should talk about is milrinone. So milrinone doesn't act at the G protein coupled receptor on the cell surface. It acts downstream. So it actually activates dental cyclase and makes a lot of cyclic AMP. And what this means, because it's starting halfway down the pathway, is that it has an inotrope effect and a vasodilator effect, but it doesn't have chronotropic effects. Okay. So you can think about it as like dobutamine, but without the tachycardia.
So Nick, absolutely. So milrinone is a really interesting agent. I think it's a pretty cool drug. At this point, I do want to bring up a key point, though, and that's that these medications work through the effects of calcium signaling. And furthermore, so calcium is going to potentiate the effects of these drugs because of that reality, but also calcium itself is going to function in certain situations as an inotrope and a vasopressor. So if someone has, for example, a low serum calcium and you give them calcium, or even perhaps if they have a relatively normal serum calcium and you give them a large bolus of calcium, you can see an inotropic and kind of vasopressor effect. Of note, calcium usually doesn't cause tachycardia, so usually you don't see a chronotropic effect. Now, with that being said, I think it's probably a good time to discuss the difference between inopressors and inodilators. So in other words, we think of inotropes not just in terms of what they're doing to the heart itself, but also in terms of their effects on afterload. Some are vasodilatory, some are vasoconstrictive. So to that end, dobutamine, milrinone, and low-dose dopamine tend to be vasodilatory. In other words, they're inodilators. On the other hand, epinephrine, calcium, and high-dose dopamine are vasoconstrictive, and so they tend to be inopressors.
You may hear a myth that isoproterenol is neutral, that it's neither a vasopressor or a vasodilator. This is probably wrong, though. If you look at the actual evidence from experiment, it's probably just a weak vasodilator. I also want to remind listeners, going back to the vasopressor episode, that norepinephrine is a strong vasoconstrictor and a weak inotrope. And that, as we said during that vasopressors episode, it's often the perfect balance for somebody in sepsis where you're correcting a low systemic vascular resistance and giving a little bit of extra squeeze to overcome that increase in afterload. That's probably why norepi is kind of the superior pressor in many respects.
Absolutely, that's right. It's going to be your first line vasopressor in virtually all circumstances, especially if you don't fully understand what's going on. You got a case of undifferentiated or mixed shock. You're generally going to be good with initiating norepinephrine as your first line agent. Now, one physiologic point I'd like to emphasize is that vasodilation isn't necessarily akin or synonymous with decreasing blood pressure. And admittedly, this is where things start to give me a headache. So perhaps, Nick, maybe you could delve into this a little bit.
Tag me in, coach. Yeah. So I guess the key point to remember here is that your MAP is proportional to your cardiac output times your systemic vascular resistance. And so what this means is that the response can get complicated, right? If you give a drug which increases cardiac output and drops systemic vascular resistance, it can either raise or lower blood pressure, depending on which of those effects predominates. Usually what happens is You get a little bit of vasodilation, a small decrease in SVR, and a big increase in cardiac output, which results in an increase in blood pressure, but not always. Sometimes people do get more hypotensive. And sometimes, what I said was MAP equals cardiac output times systemic vascular resistance. Sometimes what you'll see is that people have a slight increase in their systolic blood pressure. Blood pressure is higher when the heart's squeezing, and a slight decrease in their diastolic blood pressure. Their vasculature is more relaxed in between beats, but then the MAP stays almost the same. So that's kind of a typical response. Now, some drugs, are more potent vasodilators. So, for example, milrinone, it's more likely to cause a net drop in blood pressure because the decrease in SVR effect is more significant. But again, not always. Your results may vary, your mileage may vary. It kind of depends on the uniqueness of your patient's physiology. Okay, so now that we've kind of introduced the physiology and pharmacology a bit, maybe we should go through each of the drugs and kind of talk about kind of some of the pros and cons and quirks of each. So should we start off with our favorite, dobutamine?
Yeah, I think that's a great place to start because it's probably the most commonly used and thought of inotrope, perhaps aside from epinephrine, depending on how you look at it.
Yeah, and we should actually say that a lot of this depends on where you work.
That's a good point.
Practice patterns vary a lot by institution. I'll put a link in the show notes, but it's really fascinating that some shops use dopamine, some shops use epi, some shops really like to lead with milrinone a lot more. Some places still use dopamine.
Yeah.
It kind of depends where you trained, what your go-to is. We're both on team dobutamine most of the time.
Agreed. Yeah, I think for the most part. So, without further ado, so dobutamine mechanism of action, we've sort of alluded to this. It's a synthetic catecholamine. So it's primarily going to give you beta-1 adrenergic agonist activity with some moderate beta-2 activity. So that's the vasodilation we were talking about. What's that going to result in? Well, increased contractility with some mild increase in vasodilatory effects. From a hemodynamic standpoint, that's going to result in increased cardiac output. It's also going to decrease your SVR to a certain extent. So decreasing your SVR is akin to afterload reduction. One of the other things you'll get with dobutamine is an increase in heart rate, so increase in chronotropy, but not quite as much as you might see with other inotropes, such as dopamine, epinephrine, or isoproterenol. From a clinical standpoint, where do we use dobutamine? So in acute decompensated heart failure with low cardiac output, that's a classic case. It can be used in cardiogenic shock, where afterload reduction is beneficial. So that's another case. And in fact, you can see this in ambulatory populations as well. So it can be used for ambulatory inotropic therapy as a bridge to definitive management or for palliation.
Right. Many people go home from the hospital still on dobutamine.
That's very true. Yes, and finally, we would be remiss not to mention side effects. So as you can imagine, and I think we've already mentioned, arrhythmias and tachycardia. So because of that beta-1 inotropic, or specifically chronotropic kind of activity and tendency, you can see some arrhythmias, some supraventricular tachycardias, just general tachycardia, and that can be problematic in some patients. So make sure to watch out for that.
Right. Good, great summary. So moving on to the next one, epinephrine. So epinephrine is a potent natural catecholamine. It's a non-selective agonist for alpha-1, beta-1, and beta-2 receptors. Because it's hitting all of those receptors, it has strong inotropic effects and strong vasoconstrictive effects. It's also got very strong chronotropic effects. And because of the beta-2 effects, I just want to remind listeners that it's going to cause an increase in lactate production. Hemodynamically, it causes an increase in heart rate, an increase in contractility, and an increase in SVR. Where do we use it? Well, I mean, we all know it from crash carts, right? It's used in ACLS algorithms. We commonly use it as a third-line vasopressor in sepsis. In the setting of cardiogenic shock, especially post-cardiac surgery, we tend to use it, especially in patients who have low SVR, people who are vasoplegic, or in people who are bradycardic, where those vasoconstrictive and chronotropic effects are beneficial. And then, of course, it's also the drug of choice in anaphylaxis. In terms of its side effects or limitations, just like dobutamine, but to a greater extent, it's likely to cause tachycardias, tachyarrhythmias. It can cause myocardial ischemia. And then remember the lactic acidosis effect. We'll talk about this later, but just remember that, if one of the resuscitation markers you're using is lactate for whatever value that's worth, epinephrine can confound that trend because it will increase it.
Excellent. Yeah. And remember, again, getting back to that anaphylaxis, that beta 2 effect, which results in all of that additional lactate production, gives you some bronchodilation essentially. So that's going to help you if you've got someone whose airway is en route to becoming compromised in the setting of an anaphylactic reaction, among other benefits. So moving on to milrinone. So we've talked about milrinone already a few times. It's a kind of an interesting agent. So the mechanism of action with milrinone differs from the other agents we've discussed up until now. So it is a phosphodiesterase 3 inhibitor, a PDE3 inhibitor. It's going to increase intracellular cyclic AMP, leading to calcium influx and stronger myocardial contractions. Because it works downstream of the beta adrenergic receptor, however, and this is important, it doesn't cause actually as much tachycardia as some of the other agents. Additionally, it's got the strong vasodilatory effect, so it's an inodilator, as we've mentioned before, and it's going to decrease both, and this is important, SVR and PVR. Now, what does that all mean from a hemodynamic standpoint? So you're going to see increases in cardiac output, and you're going to see decreases in afterload, again, vasodilation. Now, the extent to which it increases heart rate, pretty minimal. So it really does not increase heart rate to the extent that beta agonists do. It is associated with increased incidence of SVT or atrial fibrillation. So you should keep an eye on that, keep an eye out for that, I should say. But generally speaking, you don't have as much tachycardia when you're using milrinone.
And I think that's a really important point, which is that just because it's less likely to cause tachycardia doesn't mean that it can't cause arrhythmias.
Right. Absolutely. Great point. And yeah, and if that, that AFib could kick off into RVR or something like that. So any of these agents that are really increasing cardiac function all have the potential to have side effects that include arrhythmia and some degree of tachyarrhythmia too. But I think milrinone probably has a little bit of a better profile with that in that regard. So as far as clinical uses, so why do we use this or how do we use this clinically? So in acute decompensated heart failure, it's a great agent, especially in patients who are on beta blockers, and especially in those that are normotensive or hypertensive, which we see from time to time. Other cases, so cardiogenic shock, especially in the setting of elevated PVR, so pulmonary vascular resistance being high. Again, you've got that profile that is associated with milrinone, i.e. the decrease in pulmonary vascular resistance. Because of that, it's surprisingly, quote unquote, used in RV failure. So great agent for RV failure because of the effect on pulmonary vascular resistance. Other places where you might use it. So in patients with significant tachycardias on other inotropes, it's a good option to audible to. And then like dobutamine, it can also be a bridge to heart transplant, mechanical circulatory support, or palliation. Finally, side effects and limitations. So perhaps not surprisingly, you can actually get hypotension on milrinone. And so sometimes that's an issue that you really have to look out for and make some adjustments to. Bigger issue in those that are volume depleted. So make sure that you're keeping these folks appropriately euvolemic. As I kind of alluded to before, while it's less likely to cause tachycardia, it still can contribute to some tachyarrhythmias, but more importantly, just has a pro-arrhythmic effect, and that can be seen in some patients. Finally, and this may be the most important thing we talk about as it relates to milrinone and things to look out for, but milrinone is renally cleared. So dosage adjustments are needed in the setting of renal dysfunction, and you may not even be able to use it. Depending on how
sometimes the dosing adjustment is turning the drip to zero and doing something else. Right. Yeah, that is one of the big downsides of it, unfortunately.
Yep.
Okay, now moving into some of the less frequently used drugs. So dopamine. So it's a catecholamine. It's got these dose-dependent effects. I'm not going to say anything about dose ranges, just to say that at a low dose, you get beta-1 adrenergic effects, and at a high dose, you get more alpha-1, causing more vasoconstriction at higher doses and an increase in SVR. It tends to have an increase in heart rate and an increase in cardiac output as its predominant effects at low dose. At high dose, it also has vasoconstriction. This is kind of a drug that, maybe has more historical use than present use. Historically, it was used in cardiogenic shock and heart failure a lot, less so nowadays. It does still get used a bit in people with bradycardia who require both inotropic support and vasopressor effects. One sort of nice thing about this drug is it's room temperature stable. So it's often the pressor that we keep in the crash cart. There's a bag of it in there. Not because we think it's better, but just because it can be stored there at room temperature. In terms of side effects of dopamine, there are a few. First off, it has a significant risk of tachyarrhythmias. In the vasopressors episode, we talked about a head-to-head trial of dopamine versus norepi that found significantly more tachydysrhythmias in the dopamine group. You may hear gray-haired attendings talking about renal perfusion benefits at low dose. I would say this is controversial to make believe. And I think even though the drug is used less nowadays, I work with one cardiac anesthesiologist who absolutely loves it, uses it a lot, and there are times when it is really a good choice. So we'll get into that more with cases. Finally, we've got isoproterenol. So isoproterenol is kind of an interesting one. It's a synthetic catecholamine. It's got pure beta effects. It's got a particularly strong chronotropic effect. So as you might expect, it increases cardiac output, it substantially increases heart rate, and it's a weak vasodilator. This is not used that often. They use it in the cardiac stress lab. They can use this or dobutamine as a stress test. And we tend to use it in the ICU infrequently, but particularly useful in cases like severe bradycardia or as a bridge to transvenous pacemaker placement. And I believe the only thing that it's FDA approved for is for bradycardias like that. Personally, I find it less useful in that setting because generally by the time pharmacy finds it and gets it to us, we've already got the pacer in, or we've already started something else. But theoretically, very useful in that setting.
So Nick, I know you said finally, but there is one other agent.
There's
I think
one
we
more.
should. We want to make sure that we've
the people's inotrope.
The people's inotrope. We want to make sure we do our listeners justice and we hit these points as many times in as many ways as we can. So calcium. We're going to talk about calcium again. So again, mechanism, as we've said now a few times, I think calcium is required really for all of the effects of the inotropes. So it's going to be a great adjunct to the inotropes that you use, but also in and of itself, it can provide you with some inotropic effects, especially in those that have a low serum calcium. And in fact, calcium is often low in folks with critical illness, and so it's always worth checking, especially if you can do so using a point of care test. And oh, by the way, that point of care test is more helpful. Why? Well, specifically, we care about an ionized calcium. And that's because ionized calcium is the biologically active form of calcium that's in the blood. It's directly available for cellular processes for muscle contraction and cardiac myocyte function, as well as nerve function. This differs from your total serum calcium, which includes calcium which is bound to proteins like albumin, which isn't bioavailable, so it doesn't really give you a full or an accurate picture of how much calcium is available to the patient to use time now for the body's cellular functions. And of course, our blood gas analyzers can often run a point of care calcium and give you that ionized calcium. So it's super helpful, easy thing to do, highly recommend.
Great point. Yeah, absolutely. I mean, if somebody tells me calcium, I'm like, what's the ionized calcium? So when do we care about this? When do we worry about this? I'm particularly worried about hypocalcemia in people who are receiving massive transfusions where they're getting a lot of citrate binding up calcium, people who are on renal replacement therapy where they're losing it that way, people who are on high dose loop diuretics, or in people who have a significant alkalosis because they're shifting the amount of ionized and bound. I think in general, if their ionized calcium is less than 1, and particularly if it's less than 0.6, you should think very strongly about giving this person calcium. And the good news is that when you give it, the effects are pretty much immediate. Sometimes it works, sometimes its effects are meh, but you're going to know within about 30 seconds. One other last point about calcium. There's kind of this wooden pearl that calcium chloride works better because of this idea that calcium gluconate needs hepatic metabolism. That's probably not true. The reason why calcium chloride works better is because there's a lot more calcium in it, right? There's 3 times more calcium per gram of calcium chloride than per gram of calcium gluconate. So, if you have good access and you have calcium chloride, sure, you can give it, but you're really just giving a bigger dose. It's not that it's magically going to work better.
Yeah, I think that's a good point. That helps me remember why calcium chloride is an agent that's typically given through central venous access,
right?
Whereas you'd give gluconate peripherally, and that's generally safe, or certainly safer to do than giving calcium chloride through especially a dinky peripheral. I mean, that's just asking for trouble.
Right. Don't give calcium chloride through that little thumb IV or whatever.
Yeah.
Okay, so now that we understand the medications, how do we know that a patient actually needs them? Cyrus, you want to walk us through this?
For those of you guys who have listened to our vasopressor episodes, which we recently rebooted, there was a method to that madness. You see, you may recognize some of what we're about to talk about. So really, the markers of hypoperfusion on exam are things that you should be very familiar with. So cool skin, slow capillary refill, oliguria, altered mental status. And as Nick kind of said early on when we were just getting started, those are all things you can really assess within a few seconds when you walk into the patient's room and shake their hand. And then if you want to take things to the next level, biomarkers, rising lactate, creatinine, elevated AST, ALT, perhaps if you see like an elevated troponin, a smoldering troponin, all of those things would be worrisome to me as it relates to a patient who may need an inotrope. You could also, if you happen to have, central venous access or perhaps a Swan-Ganz or pulmonary artery catheter, you may get a low central venous sat or a low mixed venous oxygenation. We're going to talk a little bit about the differences there in a while. So obviously an episode can't go by without us talking about point of care ultrasound or POCUS, and there are some useful applications here as well. So when we talk about the LV, you can look at the LVOT VTI, which is the left ventricular outflow tract velocity time integral. And if you combine that with heart rate and aortic valve area, you're going to get a cardiac output, and then you can even get a cardiac index from that. You could also see a low EF, or you can see an increased E-point septal separation, or an EPSS.
So lots of different ways to assess the LV, but what about the RV?
Right, absolutely. So similarly, you can look at the RV for signs of struggling by looking at the TAPSE, or the tricuspid annular plane systolic excursion. You can look for RV dilation. You can look for evidence of an increased PASP, or pulmonary artery systolic pressure. You can look for apicalization of the right ventricle. So like if the right ventricle appears to be displaced relative to the left ventricle, that can also be a sign for LV dysfunction or LV failure. So lots of things we can look at with ultrasound.
Absolutely. And I would say that, if you're going to learn to assess the heart using TTE, you might as well learn to measure some of these things too. Not just diagnostically, because it's nice to have a number, but becomes a therapeutic target, especially when you're starting inotropes.
That's right. Trending things is what we do in the ICU. So, for example, if you measure a VTI at baseline, you can make your adjustments to inotropes and then measure one again and see how you're doing.
Right. As I like to say, good critical care consists of measure something, do something, measure again, just a loop of measuring and doing.
And speaking of measuring something, we can use cardiac output monitors either continuously or non-invasively, as well. There are certain proprietary brands out there, that can do non-invasive cardiac output monitoring using things like pulse contour analysis. There's the quote unquote cheetah device that looks at splanchnic, blood flow, and as something along those lines. I'm trying to remember specifically.
I think it uses a electric field and looks at polarization of blood in the aorta.
Yeah. Okay.
Pretty cool toy.
Pretty cool toy. Yeah.
And then of course, there's things like the continuous cardiac output measuring pulmonary artery catheter, which is kind of, maybe not the gold standard, but like the silver standard at least.
Absolutely.
Anyway, we deserve a whole talk dedicated to these gizmos in the future, so stay tuned for that.
Yeah, we do, and we look forward to doing that because we like to talk about toys and all that. But really, the bottom line here is use your physical exam, urine output, biomarkers, POCUS. All those things can be used in conjunction to kind of give you an idea as to what's going on with this patient. If the person appears to be in shock, start an inotrope and then reassess all these parameters. And that's if they appear to be in shock consistent with a cardiogenic origin or with a cardiac element, right? Because again, your first line vasopressor is norepinephrine in the vast majority of cases. But if all signs are pointing to cardiogenic shock or cardiac component, by all means, make your measurements, try an inotrope on for size and see how it works, by checking again on the back end. And finally, I'll say, there are some really great measurements and calculations you can make with that PA catheter that are kind of outside the scope of today's discussion. But again, at the risk of turning this into a half-day episode, we're going to hold off on that until another day.
Stay tuned.
All right, so now that we've kind of given you guys a great foundation, I think, for inotropes, we're going to put this all into practice with maybe a few cases. How about that?
Yeah, absolutely. You want to go first?
Sure. Absolutely.
Okay.
You can do it.
So here's a 55-year-old man, comes in to the hospital with a ST elevation MI. He goes to the cath lab. He gets revascularized. He's now chest pain free. He's admitted to the ICU afterwards. Heart rate is 90. BP is 130/90. But on exam, he looks bad. So he's awake, alert, but his skin's cold, his capillary refill is prolonged. You look at the Foley bag and he's oliguric. He's made like 10 cc's all day. His lactate is 4. You throw on the ultrasound and you can see markedly reduced LV ejection fraction. His RV looks okay. How do you approach this guy?
Yeah, so I mean, I think this might be a good situation to throw on some dobutamine, and so I say that because this is someone who has pretty good RV function. You know, their blood pressure's okay for now, but really we're seeing, I think, a situation where we need to really support their cardiac output. I think dobutamine is a good option for that. So I would start titrate it up. I would look at things like urine output, skin perfusion, lactate clearance as my endpoints. As we've sort of hopefully hammered home by now, I would get my point of care ultrasound tests out of the way up front and then revisit those after I've made some changes, maybe get a VTI before, VTI after, use that to kind of help guide my decision making.
Great. Okay, I'm going to throw a twist at you though. What if his home meds contain like a high dose of beta blockers? He's on a ton of metoprolol at home.
Yeah, so I mean, I think if he's on a lot of beta blocker, then I might be thinking about milrinone. I think milrinone might be more tempting. You know, I'd be concerned about oliguria, renal dysfunction in this person, so we would have to monitor if we use milrinone. But I think it might be a great option in someone that's a little hypertensive. What do you think about milrinone in this case?
Yeah, I think it's an equally good choice probably. I think you gotta see what his next creatinine is and make sure that, his kidney function is recovering with better cardiac output. But, I think it would also be a good option. So kind of, two ways to win in this case. So let me throw a twist at you though. Let's just say that his home meds contain a lot of metoprolol. He's on a ton of beta blocker. How does that change your thinking?
Got it. Okay, so this makes things a little more interesting, right? Because if you give the person dobutamine and they've got a lot of beta blocker in their system, you might not get a whole lot of bang for your buck. And so this is a case where I would really consider maybe milrinone instead. Now, recognize that in the setting of this renal failure, we really would have to monitor very closely if you could even use milrinone. I mean, this might be a case where you're going to have to mitigate the beta blocker effect in some other way, but milrinone sounds like a good option. You just have to be very cautious about that renal function.
And we don't know, his oliguria might turn into renal failure, or it may be that you put him on a little bit of inotrope and his cardiac output goes up, his kidneys are happy again, and he starts urinating. And then you check his creatinine in the morning, and it's gone from like 1 to 1.1 or something. So it doesn't mean it's not an absolute contraindication. It's just sort of a watch carefully, make sure.
Yes. Good point. Good point. All right, so let's keep rolling. How about we do another case? I've got one for
Go
you,
for it.
Nick. All right, and this one, just for as a little spoiler alert, this is where we're going to talk about SCVO2 versus SVO2. So for our audience that's confused or has any questions, we're going to touch on that.
Spoiler.
Spoiler alert, indeed. All right, so let's say we got a 60-year-old lady who's got septic shock from a pneumonia. She started on norepinephrine and DED, and actually became more hypotensive, unfortunately. So she ends up getting some vasopressin, and her blood pressure responded well to that. Things have normalized a little bit, but she is clearly still hypoperfused, as evidenced by cool skin, oliguria, rising lactate. She's got a mild respiratory and metabolic acidosis. So you look at her with the ultrasound, your point of care ultrasound shows low LV systolic function. You've got normal RV function, fortunately. And at the conclusion of your exam, her blood pressure is kind of 90s over 40s. MAP is just barely at 60. Her heart rate's around 100. And you decide to place a central line. And off that central line, you get an SCVO2 that is 50%. So what are we going to do with all that?
Okay, so first let's unpack SCVO2, or a central venous oxygen sat.
The poor man's SVO2.
Right, exactly. And so the SCVO2, as opposed to the SVO2 or mixed venous oxygen sat, are measuring the saturation of blood returning to the heart, but they're just measuring it in different places. So the mixed venous is measuring it in the pulmonary artery when all of that blood is mixed together, hopefully. So it should be truly representative of the upper body, the lower body, and the coronary sinus. The central venous oxygen sat, on the other hand, is really measuring like at the cavoatrial junction. It's the end of your central line. And so that's probably going to be more representative of the upper body. interesting paper that will link in the show notes that came out recently that had some cool MRI imaging showing how much you can have kind of separate flows. So you can have a very different sat from the upper and lower body. And so the SCVO2 may not be representative of the SVO2. Your central venous may not reflect your mixed venous. Now, we've talked about this a lot on the show in the past, talking about like, what does a mixed venous oxygen saturation tell us? And I think about it as kind of reflecting three things. If you see a low mixed venous oxygen sat, you either have a low ability to carry oxygen, like anemia, or your body is extracting a lot of oxygen, like somebody who's at peak exercise, high fever, seizures, etc. But the most likely explanation, especially in this case, is that blood flow is sluggish. So if cardiac output is low and the blood is circulating sluggishly, the tissues will extract more oxygen from it before the blood returns to the heart. And what that means is that the saturation of blood returning to the heart will be low. Now, I should say, just a quick caveat, that SCVO2 is usually pretty close to an SVO2, but we need to be careful. We don't want to draw vast conclusions from just one number. Mm-hmm. That said, in this case, you've got somebody with a pretty clear story based on history, physical exam, labs, point of care ultrasound, and the SVO2 just kind of fits with all of that. So I'm not going to discount it. I think it probably gives us valuable information here.
Yeah, I think so too. Those are like all great points, Nick, and I think a really great explanation of the difference between SVO2 and SCVO2. Although I wish they would call it like the SCVO2 and the SMVO2.
Right.
But I'm just a poor country intensivist with crazy ideas. Anyway, like I said, great points, and I think good time to mention that, like the CVP, the SCVO2, the SVO2, etc. These are all numbers that people tend to worship or they completely ignore. So very polarizing. But the reality is that the SCVO2 is just one physiologic clue, or the SVO2, same thing. And it can help you kind of solve the clinical mystery, right? It's not a situation where you want to be like, okay, well, all of these things are pointing to distributive shock, but the SCVO2 is low, so this is definitely pure cardiogenic shock. That's probably not the right way to go about it. So again, it's a tool in the toolbox, but you got to use your brain. You've got to kind of solve the case with all of the evidence that's available, not just the one piece of evidence that you kind of want to anchor on.
Well said. Yeah, I think Conan Doyle and Agatha Christie would be thrilled by that metaphor.
Yeah, well, more like Scooby-Doo, I guess. But okay. So enough of that. What do you want to do for this lady?
Okay, so this is a patient who's borderline hypotensive. I probably don't want to add any more additional vasodilation here. So the two drugs that I'm thinking about are either going to be dobutamine or epinephrine. I'll probably go with dobutamine first, given that she already has this elevated lactate and acidosis, and she's already kind of borderline tachycardic, and I don't want to make those things worse. That said, epinephrine would be an okay option. You just have to be careful of that. My preference, dobutamine.
Okay, fair enough. Good. I like it. You stake your claim there. Here's a twist for you. So what if this lady has, you echo her again and you see, oh, okay, now I think she might have Takotsubo cardiomyopathy. What are you going to do with that?
Very interesting. Okay, so Takotsubo cardiomyopathy, also known as broken heart syndrome, it's a type of stress cardiomyopathy we frequently see in people who are experiencing intense physical or emotional stress. Classic ultrasound findings that you alluded to are like apical ballooning hypokinesis, which supposedly, I guess, if you are a Japanese fisherman, looks like the Takotsubo trap that they use to catch octopus.
As a quick aside, it's kind of cool that so someone made that connection. Someone who was both in the cath lab and is a octopus trapper was like,
yeah.
Oh man, connection. Weird.
I know. I love, as an aside, I love when things in medicine get cool monikers like that.
Yeah,
that's so much better than just some eponym.
Yeah.
It's just like very descriptive.
Absolutely.
The reason why this is a twist, and the reason why this is important, is that there is a suggestion that Takotsubo cardiomyopathy is mediated by high levels of catecholamines. And we got to be careful, because giving them more catecholamine may not be the answer. Probably a couple of things we should do right off the bat. We should check a troponin, make sure she's not, in fact, having an MI. She might even merit a cardiac cath, depending on what the troponin and ECG show. It is worth noting that some experts, including the European Society of Cardiology guidelines, suggest that in the setting of Takotsubo cardiomyopathy with low ejection fraction, you should consider milrinone over catecholamines. So in that case, assuming that she doesn't get too tachycardic and that her renal function is okay, I might go with milrinone instead. Now, the one thing we have to be careful of, though, is she's kind of borderline hypotensive already. So adding an inodilator might raise her blood pressure, but it might also lower it. So we might actually have to add an inodilator like milrinone and a little bit more afterload with like phenylephrine or increase the vasopressin. So it's one of those situations where, there's a good drug for this, but you might have to balance out some of the unwanted hemodynamic effects of that drug.
Awesome. Great points. Great points, Nick.
Okay, I got another one for you. So you have in your ICU an 88-year-old man with known systolic heart failure who came in following a syncope. In the ED, they hooked him up to telemetry, and they saw that he had a high-degree heart block. So that's why they sent him to you. Also, while he was in the ED, he had a bradycardic episode where his heart rate transiently dropped into the 20s, which he did not like, they did not like. So he's admitted to the ICU with a plan for permanent pacemaker placement tomorrow when they have a spot in EP. However, you're working the night shift. During the night, he has a long, sustained episode of bradycardia. You run to the bedside, you find him with a heart rate in the 30s, and he looks not so great. He's pale, diaphoretic, pulse is slow, BP's like 90 over 40s with a map in the 50s. So what do you want to do for this guy?
All right. So I actually think there's probably a few different ways you could manage this. So let's start with the basics. Keep it simple up front, right? So make sure the patient has some pacer pads on, be able to transcutaneously pace them if you need to. And I would really be also preparing for transvenous placement. So you're going to, transvenous pacer placement. So putting in an introducer sheath, like a cordis is one of the trade names. And then, having everything set up to be able to pace that patient transvenously. From a medication standpoint, I actually think there's probably three options, maybe even more, but three that come to mind. Dopamine, epinephrine, I think would be a reasonable option here, and then isoproterenol as well. So isoproterenol is actually we mentioned this before. I think Nikki brought this up, but it's FDA approved for this exact indication. So assuming you can get your hands on it, this would be a great option. In my shop, it's probably easier for me to get, and frankly, I'm more familiar with epinephrine. So I think epinephrine could be a fine option. It's going to cause some. It's part of the ACLS algorithm for bradycardia. So you could use that as well. Finally, there's dopamine, the sort of redheaded stepchild of intensivists, right? So I think in this case, dopamine actually does have a place. So you have evidence of heart failure, you have evidence of bradycardia, you're going to get positive chronotropic effects from dopamine. So I think it's got the advantage of positive chronotropy. It's actually pretty readily available. And frankly, if you really have to, you just crack a crash heart and there you go. So
yeah, I think it's a situation where pragmatism wins out over theory, right? Where like whichever one you can get to the bedside fastest is probably the one to start. I think epinephrine and dopamine are probably more readily available, unless he happened to come to the hospital with a bag of isoproterenol, in which case I agree, like hemodynamically, that's the perfect drug for this setting.
I'd also have to ask, like, where did you get that bag?
That's right. Yeah, like he's like a 88-year-old drug rep for
right.
Isopril.
Oh gosh. Okay. Moving on. So again, we talk about point of care ultrasound a lot. I cannot go through an episode without discussing pulmonary embolism. So this is a PE case, right? So
okay.
Let's say you got a 45-year-old gentleman. He gets off a plane. He's got dyspnea. He gets a CAT scan. He gets CT angiography, and you see a large pulmonary embolism. TTE is done. It shows severe RV dysfunction with increased PASP. He is normotensive, so he wouldn't have kind of a quote-unquote massive PE by that standard. But he doesn't look great. He's tachypnic, he's tachycardic, and you're like, this may not end up working out so well for this gentleman. Of note, he's got normal renal function. Nick, what are you going to do for this guy? How are you going to save his life?
Okay, so a lot to unpack here. We love talking about PE on this show, so I won't belabor too many of these points. This seems like a textbook submassive PE. He's not hypotensive, as you said, does not It maybe appears to be in shock, though. I mean, the fact that he looks unwell, he may be in shock and just still be normotensive. Remember cryptic shock from the vasopressors episode. So this is somebody we definitely want to start on anticoagulation. We want to optimize his oxygenation. We want to do what we can to lower his pulmonary pressures with like inhaled pulmonary vasodilators, like inhaled nitric oxide or inhaled epoprostenol. We should also immediately activate our PERT team and have a multidisciplinary discussion about what definitive therapy this guy needs. Is it going to be a catheter therapy? Is it going to be quarter dose, half dose, full dose thrombolytics? Anyway, lots of things to do all at once.
Yeah, there's a lot to do. And so, this guy, he has at least a submassive, if you go with the, ESC guidelines, which I tend to lean on those. This could be an intermediate high risk PE based on biomarkers, which I didn't give you. But yeah, definitely a worrisome case. I love the thought process of being kind of aggressive, stabilizing the patient, but then also thinking kind of in the same breath, how are we going to treat the PE? This is also a plug for our listeners to, of course, go back and listen and check out all the episodes we did on PE. We've done 3 episodes so far. We'll probably do more in the future. Lots of great discussion about therapeutics, thrombolytics, those catheter-directed therapies, etc. But yeah, let's focus on hemodynamics right now.
Great. Okay. So in PE, what we're really concerned about, the thing that is going to kill this young man is his right ventricle failing. Right. So we need to support the RV's contractility while hopefully lowering the pulmonary pressures, the RV afterload that it has to pump against. For those reasons, milrinone is a pretty good choice. It's a strong inotrope, but it shouldn't exacerbate his tachycardia, which is a plus. It's also a relatively good pulmonary vasodilator, which should help in the setting of high PA pressures and an ailing RV. We have to be careful because it's also potentially going to lower his systemic vascular resistance. So we might need to, just like in the prior case, we might need to add a low dose vasopressor to balance this vasodilatory effect out, but that's okay.
Yep, and great plug for vasopressor if you need some of that afterload increase, but you want to sort of support the PVR by keeping it low or by lowering it in the setting of RV dysfunction. And I've seen this. I've never done this myself, but you could, I guess, use milrinone as an inhaled pulmonary vasodilator. Is that a thing, Nick?
Yeah, that's right. Or at least it's a thing that people talk about. I gotta know, I've never done that because in my shop we have great RTs who can get inhaled EPO going really fast, either through high flow or if they're on a vent. But there are some people who in this setting would think about using inhaled milrinone. I got to admit the evidence for this is pretty scant, but in principle it should work. If you don't have access to something else, I guess it's something to consider potentially.
Sure.
Okay, well, should we do one more?
Let's do one more. Wait, what you got?
Okay, this is a fun one. So, 65-year-old woman comes into the ED. She's been found down at home by medics. They noted many different pill bottles at home: aspirin, metoprolol, verapamil, lisinopril, furosemide. Based on that, you infer that she may have maybe heart failure, maybe AFib. Her vital signs in the ED are pretty abnormal, though. Heart rate of 30 something, blood pressure 70/30 with a map in the 40s. Labs have some glaring red abnormalities with exclamation marks, including potassium of 7 and a creatinine of 2.5. You immediately go to see her. She's awake, but a little bit sleepy, a little bit confused. So what are you thinking right off the bat? What does this woman have?
Interesting. Great case. So just a quick aside, I think, Nick, we probably should do an episode on toxidromes in general, at least one, because this is kind of an example of one in a sense. So I think what we're getting at is like the Ohio State, the Brash syndrome. So it's an acronym for bradycardia, renal failure, AV nodal blockade or AV nodal blocker, which could be a calcium channel blocker or a beta blocker, or in this case, both, shock, and then finally hyperkalemia. So, Nick, if you'll humor me, I think I'd like to take a moment just to explain some of this. Thanks to our listeners and how it kind of works. So we'll start with our AV blockers. So we know AV nodal blockers are going to AV nodal blockers are going to slow the heart rate by slowing conduction through the AV node. AV blocker, no big surprise there. In the setting of renal failure, this can get kind of messy, particularly if the patient is on medications that are renally cleared, whether it's the medication itself or active metabolites, whatever. In this case, the patient's on 2 AV nodal blocking agents, so they're certainly at risk for drug or active metabolite accumulation. And I think it's not part of the acronym, but if they had some liver failure as well, that would probably make things even worse. But in any event, so what can happen is bradycardia, significant bradycardia. as those agents and active metabolites might accumulate. That's bad enough, but this gets even worse in the setting of renal failure because of the hyperkalemia that can often be present as well. And so hyperkalemia in and of itself causes slowing of cardiac conduction. But in the setting of AV blockers, it's going to make that even worse. So you can basically get a potentiation of the AV blocking effect due to the hyperkalemia and the accumulated AV blocking agents, overall leading to shock.
And I think it's really important to just emphasize that this is kind of like a vicious spiral, right? Where somebody has low cardiac output, which leads to renal hypoperfusion, which leads to worsening renal failure, which leads to more drug accumulation and worsening cardiac output, and around we go. Right. So that, and then as the cardiac output falls and as renal function progresses, the person gets more and more hyperkalemic. And that in turn is also going to exacerbate the cardiac function. So, this is really a vicious spiral where you need to sort of see the forest instead of the trees, right? As you correctly did, and see that this is actually all occurring together. These aren't 5 different problems on the problem list. This is one problem.
Be a lumper, not a splitter.
Exactly. Okay. So what inotrope do you want to use?
Yeah, so I think Brash syndrome is probably a good case for epinephrine. And here's my thought process. So you've got a bunch of AV blocking agents on board, and this hyperkalemia, all of which is going to sort of like slow the heart rate. So epinephrine and its impact on beta 1 agonists, or on beta 1 receptors, is going to help counter that. So it's going to increase your chronotropy and your inotropy. You're also going to see at the same time that those beta 2 receptors that are going to be activated is going to help you shift some of that potassium into the cells. So that's also going to actually treat your hyperkalemia.
This is just like when people use like albuterol to treat hyperkalemia.
Exactly.
You're doing the same thing, but you're doing it continuously.
Exactly. So I think as an adjunct or additionally, important consideration. So calcium, especially if their calcium's low. So giving some calcium is could be helpful. Obviously, we know that relationship between calcium and myocardial contractility. And finally, and this perhaps goes without saying, you're not going to want to give them any AV nodal blocking agents. So if somehow those medications are still on their med list, you want to make sure you stop them. And then consider, if there's bad renal failure, you're going to want to support them, but you may need to initiate dialysis to clear those medications.
So great summary. It was a vicious spiral that got us into this mess. You're acting at multiple different points to get them out of it. You're shifting potassium into the cells. You're increasing cardiac output to improve renal perfusion. You're taking away the causative agent. Hopefully this is going to treat the hyperkalemia, treat the shock, treat the renal failure, and of course, treat the bradycardia, which is, one of the advantages of the epinephrine. So great summary. Yeah. And actually, all of these cases really not only illustrate how we use these drugs, but they illustrate some really cool and useful physiology and pharmacology. Yeah. And just like we said, epinephrine and calcium in the crash cart, they can save the day.
All right, so folks, we've covered some great ground here today. We've talked about what inotropes are. We've talked about when to start them, how to choose between them, how to titrate them. And as we often like to do here on Critical Care Time, we finished with some great cases. Nick, that being said, there's one other question I had. So is it an inotrope or an ionotrope?
Ah, yes. Good question. It's always great to close an episode with just some pedantry. So we'll just really hit people in the head with this. So an inotrope, that's the term we've been using all episode, refers to medications that alter the force of cardiac contraction, like we said at the top. An ionotrope, it's a much more general term that refers to medications that alter the activity of a ligand-gated ion channel. So many medications are ionotropes, but only some of them are inotropes. So for example, benzodiazepines are ionotropes that act at the GABA receptor, which is a chloride channel. Ketamine has a negative ionotropic effect at the NMDA receptor, but those drugs are not inotropes. Those are ionotropes.
So does that mean that inotropes are ionotropes?
Yes. So because a lot of this has to do with calcium flux, it is fair to say that inotropes are ionotropes. But I think that's very confusing for people. It'd be kind of like if I said to you, like, hey, man, you want to go grab a beer? Instead, if I said, like, hey, man, you want to grab a liquid? Like, technically correct, but you sound like a non-specific weirdo if you talk that way.
And if we've taught our listeners anything today, hopefully it's that we don't want them to sound like non-specific weirdos.
Yes, we hope our listeners will be precise, highly specific weirdos.
Absolutely. And on that note, we hope you've loved this tour de Inotropes, if you will. We've spent some time talking about what makes Inotropes, well, Inotropes, how they actually work, which ones we consider, and all that good stuff. So again, hope you really enjoyed this episode. We had a lot of fun with it.
Yes, we clearly did. Maybe too much fun. Anyway, we've come to the part of our show we'd like to say thanks. Thanks to listeners who are listening to this, especially those who have left us reviews, comments, given us a shout out on social media. We read that. We like it. If you do like the show, please subscribe, give us a like, leave us a 5-star review. It really helps other people find the show. Please tweet at us at CritCareTime, at Nick M. Mark, at Askins_Razor. Follow us on Threads. Follow us on Instagram. Check out our Critical Care YouTube channel. Just follow us on everything.
Please do. Absolutely. And make sure to, check out the store and check out the newsletter as well. So excited about that. Now, we would definitely like to take this opportunity, as we often do, to give our sponsor, C-Star Medical, a big thanks. We're fortunate and grateful that this episode and all episodes of Season 2 of Critical Care Time are sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, cstarmedical.com, to learn more.
We should also say a big thanks to the team that makes this possible, the people who edit this podcast over at Podpaste, and last but not least, Kurt Belknap for the theme music you're hearing over us right now. If you want to learn more, about this topic, you should go check out our show notes on the website, www.criticalcaretime.com. You can subscribe to our mailing list, leave us comments. Yeah. Lots of ways to engage. Good stuff.
Absolutely. Yes. And again, check out the store if you want some Critical Care Time swag. So all of that being said, disclaimer time. So the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. With that, thanks again for listening. I am, once again, Dr. Cyrus Askin.
And I'm Dr. Nick Mark. Thanks so much for listening. See y'all next time.